Welcome to Breaking Barriers, Systemic Strategies and Solutions. Thanks everybody for tuning in today. So I'm Lori Kirstein. I'm one of the people who helps put together this project, and I'm going to be the moderator for this webinar. A few logistics first. We are going to keep our cameras off so that we don't use up our bandwidth. And all of the participants will be muted during the webinar. And for the speakers, we will be muted as well when we're not speaking. If you have any questions, especially technical issues, please put it into the question panel. Technical issues will be addressed right away. Questions for the end, however, for the Q&A session, we'll wait until the end of the webinar and we'll try to put them together. Sometimes we get questions that are grouped and it's much easier to sort of address them at once rather than individually throughout the entire hour. We're going to be sending you a post-webinar evaluation that we would appreciate feedback on. And just to let you know, we really take them seriously. The feedback that we get at these webinars helps us to plan future webinars. Next slide. Again, so I'm Lori Kirstein. I'm a breast surgeon at Memorial Sloan Kettering, and I'm the new vice chair for the Commission on Cancer. And I help to put together Breaking Barriers, and just want to say how grateful I am everybody's participating. Can't believe the year is almost over. Next slide. So on this webinar, the first speaker is going to be Dr. Lauren Jancheski. She is a general surgery resident who is doing a fellowship at the American College of Surgeons and is really mining and analyzing the data for Breaking Barriers. After the last office hours, there was a request for an update on data on how the programs are doing this year. And so that's what we are going to be giving back to you. So she'll present the data up and to and including our last data collection cycle. After that, you'll hear from Dr. Elizabeth Wick. Liza is a colorectal surgeon at UCSF. She is the chair of the Quality Improvement Committee for the Commission on Cancer on our board as well. And she's going to go over a root cause analysis, sort of an overview of how to look at a process, how to break it down to look for pain points and places where there might be areas for interventions. And to that end, the last two speakers will be Dr. Bruce Hafty, who's a radiation oncologist at the Rutgers Cancer Institute of New Jersey. He's chair of their department and a former past president of ASTRO. And he's going to look at the process they went through, looking at how to shorten radiation appointments to increase patients showing up and completing treatment. And so to be able to walk through that as sort of an easy way to, maybe not that easy, but one way to make changes in the system. And last but not least, importantly, we're going to hear from Sharon Gentry, who is the program director for the Academy of Oncology Nurse and Patient Navigators. And she's going to talk a little bit about navigation, the importance of navigators in helping our patients get through the process of treatment, and areas in the process in which a navigator can be pulled in so that they can be most helpful. So I'm going to introduce Dr. Jancheski in just a second, but just to remind everybody, in February, we're going to have the cancer programs meeting February 22nd to 24th in Austin, Texas. I'm going to remind you again at the end of the webinar, but it's really all things cancer programs related, including a large session on these quality improvement projects. And also, if you want to learn a little bit more about quality improvement, there's going to be a short half-day course on quality improvement. We have abstracts that we've accepted on the different quality improvement projects, so we encourage everyone to attend. So with that said, next slide, Dr. Jancheski, I turn it over to you to present our data.
Thank you, Dr. Kirstein. Next slide. So this is based off of our most recent data collection period, which ended at the end of October, and doesn't include any of the additional prior data, although I will do some brief comparisons later on. When we initially pulled our data, we had a total of 329 programs who had submitted at the time of the data pull. And interestingly, what we found is that about 93% of programs said that they have been able to identify the most common barriers for why patients missed scheduled radiation treatments. And similarly, 93% have also been able to prioritize which barriers they think will have the most impact on reducing future missed radiation appointments at their organization or program. So overall, the vast majority of programs throughout this process have been able to identify and prioritize the barriers that they think are impacting their patients most, and hopefully will be able to select and implement interventions based on these specific barriers. Next slide. This is based off of the questions that we've been asking similarly throughout the whole year one process in participating with breaking barriers. So approximately 77% of programs reported that they had patients who missed 3 or more missed radiation treatments. This is fairly similar to what we've seen throughout the course of this project so far. Most programs throughout all of our data collection periods have reported somewhere around 77 to 80% of programs who have identified patients missing multiple treatments. However, the median percentage of patients at each individual program who missed radiotherapy was about 7% in this specific data collection period. Importantly, the interquartile range, or the 25 to 75 percentile range, was 1.7% to about 3%. I've plotted these on a bar graph that you can see on screen right, which shows the lower quartile in blue, the median in red, and then the upper quartile in the grayish color, comparing our baseline data to midpoint and now to current, which is highlighted in the red box. And importantly, what you can see is that over time, the median percentage has gradually declined, but most importantly, the upper and lower quartiles have really decreased as well, which shows that even before our implementation phase, we've been able to demonstrate decreases in patients who are missing multiple radiation treatments. Next slide. This is similarly demonstrating missed radiotherapy treatments by disease site, which we've done in the past as well. The total number of patients in this data collection period missing 3 or more treatments was almost 700 patients, which is lower than before and approximately 7.7% of our total patients. Next slide. Similarly to what we've demonstrated in the past as well, patients with breast and prostate cancers were least likely to miss 3 or more radiation treatments. Next slide. But interestingly, what we've seen in this data collection period so far from October is that patients with gynecologic and lung cancers were more likely to miss multiple treatments, where previously we were seeing that patients with upper gastrointestinal and rectal tumors were more likely to experience that in the past. Next slide. Now, with the specific reasons for missed radiotherapy, our current data based on this most recent collection is in orange. And what we found is that the most prevalent barrier that programs are reporting was transportation in this round, followed by illness unrelated to treatment toxicity, then conflicting appointments, and then no longer wishing to pursue treatment. You can see this is very different from what we've analyzed in our baseline data, where previously illness unrelated to treatment toxicity was the most highly prevalent barrier. Additionally, the number of programs reporting conflicting appointments and no longer wishing to pursue treatment were also much higher as well. We didn't ask any specific questions with regards to the reasons for these changes, but we suspect that perhaps programs are already demonstrating improvement in following up with patients and asking them more pointed questions on perhaps why they're missing treatments in order to get at the root cause of the problem. Next slide. Lastly, I'll just share a few data points in which we asked you all to select or say which barriers you have so far chosen to address as we approach the implementation phase of year 2. You can see in the bar graph here that the majority of programs are looking to target transportation as well as illness unrelated to treatment toxicity, which again, even regardless of the differences that we saw between our baseline and current data, these two are the most highly prevalent barriers that are reported amongst our programs. And about 60 programs said that they're wishing to tackle conflicting appointments, which hopefully you'll be able to gain some more information throughout the rest of this webinar on how to tackle that specific barrier throughout this hour. Additionally, we had about 70% of programs who said they already have a plan in place to address the barriers, as well as 60% of programs have already identified programmatic and or community referrals to help address these barriers as well, which is great. Importantly, though, we'll be providing a toolkit to help for those 40% of programs who haven't identified those programmatic or community referrals yet, or the 30% who don't have a plan in place, to help you address your chosen barriers as well. Next slide. Thank you, and I'll turn it over to Dr. Wick for the next portion of the webinar.
Dr. Wick is going to be talking about how to approach problem solving and root cause analysis. Dr. Wick, are you on? She was in ambulatory surgery, so I'm hoping that she's still. Oh, great.
Couldn't figure out how to unmute. So
you're there.
Okay.
We hear you.
Excellent. Am I advancing the slides or you guys?
You tell them to advance your slide. Just say next slide and she'll do it for you.
Okay, perfect. So thanks so much, and it's an honor to be here. So excited to see so many people interested in getting better. So as Lori said, I'm a colon surgeon at UCSF and have been involved in quality improvement in a wide range of things. Next slide. And I thought I'd just, this is kind of how I got into this. And I think it's a little bit illustrative about how to approach problems, and maybe I'll just give you some ideas, some tools and other approaches. So I got into this in 2010 when I worked at Hopkins, and we participated in a NSQIP program at the time that was a pilot that showed that our colorectal surgical site infection rate was we are far to the left. We were one of the worst hospitals in the country. So it was sort of our first window into our outcomes. And, you know, we were shocked, and, you know, kind of as you're looking at your breaking barriers data, maybe you kind of always knew this was maybe a problem, but now you're seeing it in one place. And so then we really ran with it. And I'm not going to dwell on colon SSI today, but I think just share you some approaches that we used back then that are pretty simple, that might be things to use as you think about your breaking barriers data. Next. And so at the time, I worked closely with an intensivist who had done some work in the state of Michigan around thinking about how to improve. And so we partnered with Peter Pronovost. He's the intensivist who did a lot of work around central line associated bloodstream infections. And he was really ahead of the time, really thinking about who needed to be part of this quality improvement. When you looked at your data, who could really weigh in and help you solve it? And for us, this was super helpful, and I have some ideas on how I think this could be applied. Some of these same principles could be applied to your breaking barriers work. He really focused on thinking about the frontline folks, the people who touch the patients, really having them understand the problem, be part of the solutioning, think about the systems that, you know, at the time it really wasn't as electronic health record focused as it is now, but the systems that we have and how we can improve those systems, and really thinking about the people who touch the patient, the people who check in the patient, who make the reminder calls, who walk the patients to the radiation room, you know, just really take advantage of all of those people who interact with the patient to have, gain a deeper understanding of why patients might be missing appointments. Granted, you wouldn't have them on the day they missed the appointment, but you would be able to interact with them on other times. And then some of these things that you identify are going to be hard, and I think that's why the great thing about the cancer programs is there is the connection to the leadership. You know, whether you want to change something in the EHR or change a workflow, there needs to be senior executive engagement. So just think about your breaking barriers team today, and, you know, just while you're sitting here listening to me, do you have that senior level of engagement? If you need to change something in the EHR, could you get that change to happen? I know for so many of us it is so hard. But I think thinking about who's on your team, both who's on the front line, who's on your side fixing these problems, and who is that senior executive is really helpful. And then I'm just going to go through on this talk an example of how we use this idea of investigating defects for colon SSI, and then throw out some ideas about how I think you could do the same thing here. So next slide. So this is just a really simple thing to think about. Say we take, and this is just used, I'm going to show you how we used it for SSI, but you could think about reframing these questions with your frontline folks about why are patients missing? You know, why do the patients have trouble with transportation? And then what can we do to prevent how can we better support the transportation? Or back in my example, we asked all the frontline staff, all the folks who touch the patient, how will the next patient have a surgical site infection and what can we prevent them? And then I'm just going to show you the really simple things that we came up with using this approach. Next. And so this seems really intuitive, but again, this is just, I'm hoping I'm teaching you that hopefully you'll walk away with the power, understanding the power of really getting to involving the people who touch the patient. So, you know, this was 2011 and all patients should be getting antibiotics before they went to the OR. And, you know, we'd had CMS and regulated, there are all sorts of regulations. And, but, you know, when we actually tapped the frontline folks, they said, you know what, the patients who have allergies to penicillin, you know, we aren't, a lot of times the surgeons are telling us not to give it because they're not comfortable with our alternative dosing regimen. You know, sometimes we don't even know how to dose it. We can't calculate it. And sure enough, when we dug in, we found that that was true, but it had been kind of slipping through the cracks because it was not every patient. And then we worked with the front line to fix their problems. I won't go into the details since it's not relevant here, but again, that real partnership surfaced problems that that were just sort of skating under the surface. And then when we thought about the systems answers, they were systems answers that really worked for the front line and the patient and the team. And so I think, you know, just thinking about your data that you have, approach it like that. So next slide. So I just wanted to bring it back to this Breaking Barriers project, and just kind of push you while you're sitting here listening to this webinar. Just take out a piece of paper, think about, you know, who could help you at your hospital solve this problem, and really understand who could be part of this. And you know, it's so hard to get people to come to meetings, but can you reach out by email? Can you ask patients in a little survey monkey, ask these folks in a survey monkey for their ideas, you know, be creative about brainstorming. So just, you know, think about all the patients, all the people who touch the patients, the person who checks it in, the text, the registrar, the registration, navigators, and then thinking broader, you know, do you have social workers, case management, are there community health workers, primary care docs, oncologists, patients, families, just, you know, think about who really creatively, who is the team for problem solving in your community. And then next slide. And you can start to, you know, think about how to crowdsource from them ideas on why the patients are having trouble with their rides. You know, I think we just assume too many things, but getting lots of input generally leads to a better solution. And then once we have those ideas, thinking about how we're going to learn and solution. So next slide, or next advance. So again, focusing on because we're missing radiation because of the lack of a ride, thinking about the contributing factors. Advance. And then just thinking about, you know, do we send reminders? Do we reach the patient with the reminders? What happens if the patient doesn't acknowledge the reminder? Is it a text? Is it a call? Do we talk about the appointment at the prior appointment? Who is the larger team supporting the patient? You know, and then if someone doesn't show up once, how do we change how we approach the patient the next time? And I think just really thinking about who is that little group of people at your hospital that can brainstorm and really map this out. And then think about once a patient misses one appointment, maybe a goal is to have them not miss that second appointment to problem solve and troubleshoot, and just try to support a patient so it just incrementally you have fewer and fewer numbers of missed patients per patient, missed appointments per patient. Next slide. Oh. And so these are just, I can send them to Shay, that these are the, from all the stuff I shared has been funded by the Agency for Healthcare Research and Quality. It's all available. All these tools are available to help think about problems. I would encourage you to consider them, or other quality improvement methodologies that you have at your hospital. These are super simple. They're really made for the layperson to use. That 2-question survey, just asking people, you'll just be surprised at all the kind of comments from people that you just wouldn't think of asking about why things are happening. You get a lot of really helpful input, and then really understanding how to learn from that. So that's my thoughts. Next slide. So I just wanted to emphasize that you guys are all amazing for taking this on. It's really hard. I think the joy in this is with the patients and really the frontline staff, and making all of our work kind of more meaningful. And so I think you'll just find when you tap the front line, there's a lot of a lot of interest in helping patients and having their voice heard. And don't overthink the solution. Some of the simple solutions are the best. And then, at the micro level, measure what you do, because, whatever process you put in place, measure it so you know whether you need to iterate or improve. And you can do this with simple audit tools. I know we all struggle with the EHR and updating it or getting data reports, but think about small ways to audit. And then, Lori's developed an amazing Breaking Barriers community. So lean on this community, collaborate, hear what others are doing. And we too often reinvent the wheel. So you're not in this alone. So with that, I'll turn it back to the team.
Thank you so much, Dr. Wick. She is fabulous. She's is there an ambulatory surgery center? So if she has to log off and isn't available for the Q&A, first of all, thank you for doing this, but also we are going to make these slides available on our Breaking Barriers website, as we do with all of the webinars. It was a question in the chat already, but that way, if you have, you want to log into the link that Dr. Wick put onto her slides, that will be on there for you. So without further ado, our next speaker is Dr. Bruce Hafty, who's going to talk about some simple solutions to decreasing radiation appointments to try to increase compliance with care. Dr. Hafty.
Thank you. Assume everybody can hear me okay. I'm going to talk about potential solutions in breast cancer. Next slide. As you've seen, multiple studies have demonstrated that interruptions or compliance with the course of radiation can impact outcomes. Preliminary studies from this ongoing project obviously confirm that missing 3 or more radiation treatments does remain a significant issue in patients undergoing radiation. May not be as prominent in breast as it is in some others, but it's across the board. It is an issue. And recognizing the possibility of compliance issues with radiation and intervening with appropriate solutions is an important goal. Next slide. So the potential barriers are economic, work schedule, cost of transportation. So that could be an issue with some patients. There are social issues, child care, or family care. I have a patient currently on treatment who has difficulty because she takes care of her husband full time and sometimes has difficulty making it in because of his needs. There's a dependence on family or friends for transportation. And also, keep in mind their compliance with other healthcare. Many patients, at least getting radiation, have previously received surgery and chemotherapy, and sometimes you can find out from the medical oncology and surgical oncology teams whether or not there are issues with compliance in their care to date. There's obviously travel distance issues. Daily trips are inconvenient. If a patient, is visiting you in radiation from a home that's 50 miles away or more, that may be an issue. And then there's other general issues which I speak to, and that's kind of more just a sense that as you're talking to the patient that they're not pleased with the idea of coming in daily. They don't really appreciate the need for treatment, and they give you kind of subtle messages and hints that they may in fact be not compliant. Those are all things to kind of look for at the time of consultation that may give you hints that there may be barriers here. Moving on, next slide. So what are the potential solutions? Well, obviously for any of the socioeconomic issues, engaging the social workers immediately is important. Travel distance issues are obviously consider referring the patient to a facility that's closer to their home if that's a viable option. But if that's not, consider alternate radiation schedules that are appropriate. And I'll be talking more in detail about that in breast. But and general issues are whatever the reason is for potentially not being compliant, consider social work intervention, perhaps more in-depth discussions if you sense that the patient is just not convinced that radiation is needed every day, or that they're not convinced that they need radiation. You might get into a more detailed discussion about the importance of it. and if appropriate, consider alternate radiation schedules. And while I'll focus on breast cancer, I will point out that shorter courses of radiation have been developed or are in the process of being developed for multiple sites, including prostate, head and neck, lung, GI, etc. So getting shorter radiation courses and what we call de-escalation of therapy is really a major area of ongoing research and ongoing patterns of care which are appropriate. Next slide. So 5 to 6 weeks of radiation had been the standard for years, and this has been a significant issue for many patients. In fact, we know from a lot of data that we have available that many patients have elected mastectomy over breast conservation simply to avoid the issue of coming in for daily radiation. However, currently there are options in appropriately selected patients that can help to avoid interruptions in the radiation schedule, shorten the course of radiation. And for any patient, particularly those where we anticipate potential interruptions, should at least think about alternate radiation schedules. Next slide. Now, the following slide is a courtesy of Trey Shelton, who's a radiation oncologist in rural North Carolina. And they did actually a retrospective review of breast cancer patients treated in a previous era where 5 to 6 weeks was a predominant schedule to a more recently when 3 to 4 weeks were the predominant schedule. And what they found in the next slide is that accelerated radiation, the 3 to 4 week course, was adopted relatively quickly compared to the historic 30 treatments. Breast conservation rates increased as a result of the less treatment, 48% to 79%, and missed appointments due to barriers, whatever they happen to be, and they defined it as missing a single treatment, but were lower with the accelerated courses of radiation. So accelerated courses of radiation can impact in compliance to the course of radiation. Obviously, when it's 6 weeks of treatment, you're going to have more reasons that they can't make it. And if you can get it down to 3 to 4 weeks, or as I'll show you, even as simple as 5 treatments, then compliance becomes less of an issue. Next slide. So this slide just shows a bunch of alternate radiation for whole breast radiation, alternate schedules. And I've highlighted those that are used kind of that are, at least in the United States, the most frequently employed and with patients. First is the OCOG, or the Canadian trial, which is basically 4 weeks of radiation, if you will, 16 treatments, and then a boost if you choose to do the boost. The START B, which is 15 treatments, 3 weeks with or without a boost. Then there's the RTOG trial, which has not been fully published yet, but that's what we call a concomitant boost. It's basically giving the entire treatment, including the boost, in 15 treatments. And then what's really become somewhat popular, certainly in the UK and increasingly in this country in some patients, mostly older patients, is simply 5 whole breast radiation treatments in 5 days. And that's been all of these studies and all of the studies on this slide, including those that are highlighted here, have been demonstrated in randomized trials to be equivalent to the longer courses of radiation. So not only equivalent in terms of local control, but equivalent in terms of side effects, toxicity, fibrosis, etc. So all of these are legitimately studied, validated, randomized studies that show shorter courses of radiation are as effective as the longer courses of radiation for the patients who they are who are eligible for those trials, appropriately selected. Next slide. And this is just a graphic showing, the 6 to 7 weeks and the various courses of radiation with or without the boost. The boosts are the black dots there, and you can see that you can get shorter and shorter, including the fast forward with 5 whole breast treatments. So if you have a patient that you know is, and I've had patients who basically came in with the idea that they were going to refuse radiation or were not thinking about radiation, and offered them 5 treatments of radiation, and they've said, oh, okay, 5 treatments, I can deal with that. So it does help to convince the patient, particularly if they're reluctant, or if they're going to if you anticipate that they're going to have significant barriers because of socioeconomic or transportation issues. Next slide. So I think, clearly with, what all these trials show is when you're treating the whole breast, which is the most commonly approached treatment, although that's changing to partial breast in many centers, uh, uh, you certainly can treat it when you're not treating the regional lymph nodes. You can do it in 3 to 4 weeks and as fast as 5 treatments. The only thing that some people are, and including myself, are somewhat conservative on the fast forward 5 treatments, is that the follow up in that is only 5 years. So we'd like to see longer follow up. And so I tend to not do that in younger patients very much, but I've done it in other patients that are older, and it's worked out quite well. Next slide. Now, when you're treating the regional lymph nodes, we typically do the 5 to 6 weeks, and that's the current standard of care in this country. It's actually not the standard of care in the UK, where they do it in 3 to 4 weeks, and there have been many trials doing regional nodal radiation over 3 to 4 weeks, but that are acceptable. Next slide. We did a trial here at Rutgers with 3 weeks of radiation post mastectomy, with or without reconstruction, and in a phase 2 trial got acceptable results. But more importantly, that led to a phase 3 trial, which is in the next slide, I think. Next slide. Yes. So this is a phase 3 trial. It's now closed. It did incredibly well in terms of its accrual in less than 2 years, so 2 to 3 years, where patients were randomized to 5 weeks of radiation versus basically 16 treatments, 25 treatments versus 16 treatments. And importantly, these patients not only had mastectomy, but reconstruction, where many people are reluctant to shorten the course of radiation. This trial is closed, but it will be reported, we think, within a year or so. And we hope that show that that's effective, and so that I personally feel comfortable treating some patients with hypofractionated radiation to lymph nodes based on other data, but this trial hopefully will help to confirm that. Next slide. And this trial was already actually done in patients with mastectomy without reconstruction in China, and they did show that the 3 weeks of radiation was as effective as the longer course. The only caveat is that this patient group had mastectomy without reconstruction, so some people are still somewhat concerned if a patient has had reconstruction or is going to get reconstruction, that the faster courses may not be okay. My sense is that they will be fine, but the RT Charm trial, which I just showed you, will show that, as well as another trial which has already been reported in an abstract form. Next slide. Okay, well, this just is a result of that, the Chinese trial, which showed no difference in any endpoints, 3 weeks versus 5 weeks of radiation in patients treated to the chest wall and the regional nodes, but without reconstruction. Next slide. And at just our last ASTRO meeting, preliminary results were reported on the Fabric trial, which is very similar to the RT Charm trial, 16 treatments versus 25 treatments. Their primary outcome was toxicity profile and quality of life. And they actually did show fewer treatment breaks with hypofractionation, less financial toxicity in that trial. So, so even when you're treating the regional lymph nodes, and even though the 5 to 6 week course is the current standard, I think we are rapidly moving toward the 3 to 4 weeks being an acceptable standard. And certainly many patients can be treated with that regimen of 3 to 4 weeks. Next slide. And in fact, our European colleagues have already concluded that moderately hypofractionation, which is basically the 3 to 4 week course of radiation, can be offered to any patient with whole breast, chest wall, with or without reconstruction, and nodal volumes. So at least the European Society has at least come up with that as a recommendation. I think in this country, a lot of folks are waiting for the results of the RT Charm and the Fabric trial, particularly in those patients who had reconstruction. And also note that the Fast Forward trial, which is 26 gray and 5 fractions, did include a subset of patients with regional nodal radiation. So we'll hear about that at some point, but they haven't reported on that subset of group of patients. So it may be possible that even in patients with regional nodal treatment, that you could do it in 5 treatments, just like the whole breast. Next slide. And that brings us to partial breast, which is also very acceptable in a large group of patients, particularly those with early stage node negative and DCIS. And there are a number of fractionation schemes based on randomized trials, and this has increased significantly over the past few years. Next slide. And when we look at external beam partial breast trials, these are just a handful of them that have been reported, but these are all, again, randomized trials that have shown equivalent results with partial breast versus whole breast over a longer period of time. And I think the one to me that's most appealing is the Florence trial there, because they have 10-year outcome. That's one thing that's important. They compared 5 weeks of radiation to 30 gray in 5 treatments. So 5 treatments every other day, and showed that it was the partial breast was non-inferior. Again, in those patients selected, so generally node negative, ER positive, favorable breast cancers. But this is a very appealing approach in patients where they can be done in 5 treatments every other day. And so you can imagine that if you see a patient who has potentially some issues with transportation or any other potential barrier, and they are eligible for this, they have early stage node negative breast cancer, certainly that regimen of 5 treatments to the partial breast is a very, very desirable and viable option. Next slide. Partial breast has been used, and we did many studies, including NSABP, which is 38.5 gray and 10 fractions twice a day. That's somewhat inconvenient, and there's some evidence that it may be a little more toxic, and that's why I particularly am more favorable to the Florence trial of 30 gray and 5 fractions every other day. And it could even be done every day, according to a recent study from the Florence group, but the original trial did it every other day and have no problems. And I've treated many patients with this regimen. Next slide. Just wanted to bring this trial to your attention. It's an interesting trial in patients over 70 happening in Europe right now, because compliance with radiation is one issue, but compliance with tamoxifen, hormonal therapy, is another issue, and oftentimes because of the some of the side effects and whatever. And this trial is ongoing in Europe, taking patients over age 70 and randomizing them to either 5 radiation treatments, usually partial breast every other day, or 5 years of tamoxifen. I don't know how the study is going yet, but my prediction is that the radiation arm will win, and because the endpoint is quality of life and side effects and that sort of thing. And I would imagine that the 5 radiation treatments have very little side effects as opposed to the 5 years of hormonal therapy, but we'll see. That's a trial that's ongoing. Next slide. Radiation can also be delivered by brachytherapy. This is not done as commonly because it takes some skill and some experience, but it can be done with interstitial radiation. It can be done with a balloon-based mammocyte, which you may have heard of. We did a study called the Triumph trial, where we did a single balloon catheter treatment over 2 days. So these are all options. And another option, so partial breast cannot only be done with external beam, but it can be done with brachytherapy, coordination with the surgeons, obviously, in this. But this is an option for those patients, for those centers that do brachytherapy. Next slide. And data from our European colleagues, something called the Target trial, which uses an intraoperative orthovoltage radiation device or intraoperative electron beam. Both of these have been done in randomized trials showing acceptable results in selected patients. And so these are other options for patients where transportation or compliance with a course of radiation might be an issue. But again, can only be done in those centers that offer this type of treatment. Next. And again, both the Target and the Elliott trial have shown mature data with long-term follow-up. Although local recurrence rates appear to be slightly higher in the intraoperative arms, they're acceptable in those patients who are eligible for the trials. Next slide. So I think multiple factors should be considered in evaluation of patients undergoing radiation that may signal a potential lack of compliance with the radiation schedule. That could be work conflict, childcare, family issues, distance, socioeconomics, or history of non-compliance in general. And when those patients you're seeing, you think that there may be an issue, certainly alternate radiation schedules have been shown in, breast cancer is common enough that we have great randomized trials and great data that show that these other programs are effective and both from a economic perspective and toxicity effective and local control so we're not doing something that's not standard of care. These alternate fractionation schedules that I've shared with you have been shown in randomized trials to be acceptable and can be considered a standard of care. Again, for those patients who are eligible for the trials, selected patients who meet the criteria for those 1 to 2 week courses of therapy or a 1 week whole breast. And one should consider those as alternatives. And as Trey Shelton showed in his study, and they showed in the Fabric trial, the shorter courses of radiation can result in better compliance with the course of radiation. I think that's it. Thank you.
Thanks, Bruce. And so for everybody on the webinar, first the question area is open. I only have a few questions that have been submitted so far, and after this next talk, we're going to be addressing your questions. So please do post them in the chat. And just to say, Dr. Hafti has been incredibly convincing about shortened courses of radiation for breast, and you'll see that if you want to have that in the slides that we put up. But there will be also a quote unquote like cheat sheet that we're going to make for people on the different fields, so the different cancer subtypes, and approved shortened courses of radiation and what they are, to make a little table for everybody to make that available. We recognize it's not easy to go back and tell your physicians to change how they practice, but in fact, if there are upgrades to the standard of care that could improve compliance with treatment, certainly that would be an option, and we want to be able to give you that information. So with that, I'm going to introduce our last speaker. Sharon Gentry is going to talk about nurse navigation and talk a little bit about the process of nurse navigation and where nurse navigators may be helpful for patients to get through their course of treatment. She'll probably talk for about 5 minutes or so, which will leave about 10 minutes for questions if we need it. Sharon?
Thank you. I'll be glad to talk very quickly here as I try to preach the history here we've got of navigation as we move through the treatment continuum. So if you could go to the next slide, please. Just want to show you that we have worked since 2015 to show value-based care around navigation. We have 35 standardized metrics that can be applied to any navigation program, any size navigation program, NCI, community. However, that can show with navigation, and when the three main navigation components that we have right now are patient navigation. They do not have the clinical license. The nurse navigator and the social work navigator are the ones that we recognize. You can make a difference in clinical outcomes. You can make definitely a difference in the patient experience, and I'm going to show a little bit more how you can make a difference on return on investment. I have asked this question before, just been really real curious of how many of these sites already had navigation in place. And when I talk about navigation, I often get asked this question, so what's the difference in a navigator versus a radiation nurse, a chemo nurse, infusion nurse? The biggest difference is your navigator sees that journey that patient takes holistically. They're not siloed in the radiation department, in the infusion room, in the inpatient oncology, or even out in the free imaging. They actually follow that patient through the time they come through the door, all the way through treatment. So it does make a difference. Next slide, please. Just want to, so also now through the big push to health equity, that we are now one of the truly evidence-based solutions of how you can increase health equity for all your patients. Have been several studies showing the difference, especially in breast and especially in lung. When that navigator brings that patient into the system, looks at what are their social determinants of health, what are the barriers that are going to prevent them from even getting to the surgery versus the radiation versus whatever, that they bring these patients and give them equal footing to get through the system on standardized care. Next slide, please. I want to talk a little bit about return on investment because that gets everyone's attention when you talk about money. The first one was a study that was done back in 2011, so really before we become more of a nationally recognized service that we are now. This was a gap analysis that one system saw many, many patients leaving their system. And they realized that when they put the patient or the nurse navigator into the system quicker around that patient contact, that they truly kept patients into the system. And so, and it shows, and they took and followed the patients throughout of how much money they brought in the system. So I had this study here to say, I understand your idea is to catch them when they're in radiation and they've already missed several treatments, but we've got many, many studies that show the value. The sooner you can start navigation in the care continuum, the more often that patient will stay in the system and understand the system. The other one was in the middle here was done in Utah, where they did a nurse navigation, and all they did was much more education. I was excited to hear about the awareness of the problems that patients give you for not coming to radiation or missing radiation, and how many of you have been reactive to that problem solving. I would almost challenge you now, let's be proactive. The better educated that patient is coming in the system to understand whether it's going to be surgery first, chemotherapy first, and then you get on the radiation. This is what your radiation will entail, and you just heard there's many different programs they could be experiencing. But as long as the patient knows up front what to expect, you're addressing some of those major barriers already of transportation, conflict in appointments, grandparents bringing in young children, all that's being addressed proactively up in the system. It's almost like you do a gap analysis with all your team members to get that team approach. And then there was this one study that came out in March of 2013, and this was in radiation. Each patient was contacted at least once a month, and the more at-risk patients were being contacted as often as 3 times a week. Who are those more at risk? That's what you're going to have to identify. Who are the ones that you foresee are going to have trouble getting through that treatment? Who are the ones that are not coping as well as they go through treatment? And many times that navigator can start having that conversation with the treating team and the lead physician to say, we need to be more aware of what's going on with this patient. But in 3 months, the reduction in no-shows and those receiving radiation therapy equal to navigator's annual salary. So they basically paid for the position in 3 months. And they showed their overall return on investment was $5 for every $1 spent. It also trickled down to readmissions. The readmissions to the emergency room were also cut by a third. So emergency room didn't get any money, and you actually saved the patient money and was able to pay for the navigator there. I will share with you, when I looked at the different cancers that you're looking at, one of the challenges that we see with many of the GYN navigators is many of their contacts change over time. A lot of these people use prepaid phones. travel, move around with families sometimes when they're facing that GYN oncology care. And so what they've come to find out is they try to get another number from another family member or even a neighbor, someone in the religious sect who they were very close to the patient. And all of a sudden, if that number doesn't work and they can't get hold of that patient, they're often finding there has to be an alternate way to get hold of them if it's possible. I'll just share that little pearl of wisdom that seemed to work a whole lot better with the GYN patients, as we've heard from the navigators. Also, you have to understand that we understand the radiation therapy waiting room used to be what we called our little gossip room. And we would often find out what are they talking about. These people compare their treatments. So I appreciate all the new radiation, different types of schedules that are coming out. But your patient needs to understand this is why we're treating you with this many treatments or this many booths. Other people, you can actually say other people get other treatments, but this is specialized for you, for your care, and we want you to stay into the system for care. So a lot of proactive education. Get your navigation started just as soon as you can. And it'll be kind of like that, like a seamless thread for that patient. That navigator will go through the system with them. Next slide, please. And this is just a visual. Your navigator has this unique view, that kind of holistic view of the whole care continuum that patient takes along. And you see that it's going to be a curvy road. We hope these curves don't come back upon each other, but it's a very curvy road that a lot of these navigators take forward. And that's my talk. I don't think there's a next slide.
Thank you so much. I think we all understand the importance of nurse navigation. I think some of the information on return on investment is super interesting, and the COC is interested in that kind of information for 2024, some of our standards as well. So let's see, looking ahead, what to expect. Next slide. So we're going to be entering our last data collection period for 2023. It will open up on December 15th and close on the 30th. We recognize it's over the holidays. Hopefully people can get it in. If not, we understand, maybe a little bit late, we get it. But that will be the last data collection period for 2023. Next slide. Starting in 2024, so I'm just gonna add right now, so there were some questions about participating in 2024. You do have to fill out the application. It is not quite as in detailed. It's basically, are you going to participate, yes or no? And I don't think it's much more than that. And then you don't have to necessarily let us know by the end of 2023. Somebody had asked that question, but you have to let us know by the beginning of the first data collection period in 2024, which I believe is going to be February. So in 2024, the idea is implementation for the first part of the year, and then by the end of the year to talk about sustainability as well as potentially scalability. And we'd like each program to identify at least one barrier in which they will develop a problem statement and goal, and then we will be providing toolkits for interventions that can be implemented. We are actively working on this. So once you choose your intervention for implementation, then we're going to ask you to just continue to enter your data so we can see if it makes a difference or not. And the hope is that somewhere in 2024, we'll be able to get some cohorts together to meet up in small groups. So for example, people working on a transportation barrier may all want to get together, or people in the rural America who are working on a transportation barrier may want to get together, etc. So we're hoping to set up some cohorts so that you can share practices with each other and resources with each other as well. Next slide. Okay, a reminder, next slide, is the Cancer Conference. I mentioned it at the beginning of the hour. The ACS Cancer Conference is going to be February 22nd to 24th in Austin, Texas. Again, there's going to be time carved out specifically to the National Quality Improvement Projects, including breaking barriers, as well as a half-day course if you want to learn a little bit more about doing a quality improvement project. It's very small and it's supposed to be very interactive. You will not just be sitting in an audience asking, listening to a lecture. It'll be bring a problem that you want to work on. Let's help you work through it. It's meant to be really hands-on and interactive. So this is the link to the Cancer Conference if you want to come. Next slide. And with that, let's just see the Q&A. My goodness, now they're coming in. Now they're coming in fast and furious. So let's see. I talked about the applications. Let's see with the navigation. In the perfect world, we'd have a navigator to see every new patient. Yeah, that would be great. That's hard. I think the COC can help with that coming in the future. We're trying to work on how to get you guys supported with navigation. I didn't participate in 2023. Yes, you can participate in 2024. The application is going to be open if it's not open already. And I think I got an email about it today. You can. The application is the same application as the programs filled out last year. It asks some baseline information about attitudes and readiness. The difference for the programs that want to participate in 2024, you need to be able to retrospectively collect 6 weeks of data. And so we allowed in 2023 our programs to do a prospective 6-week study. We ask that you give us retrospective data. And so that means you have to have a little bit of you have to be a little facile with your radiation oncology software in order to be able to identify the no-shows. If you're interested and you're having difficulties, please let us know. You can always email us at the ACS and we can help you with that. We'd be happy to jump on a phone call if necessary. Yeah, the 24 says don't fill out it says don't fill it out. You don't have to fill out the full survey. You just have to fill it, are you participating in 2024, yes or no? That's the only thing you have to do. How will surveyors be assessing for compliance with breaking barriers? If you participate in breaking barriers, you're receiving credit for your 2 standards. You're receiving credit for the barrier to care standard and the QI project standard. You cannot use the breaking barriers for other standards, such as the screening standard. And so you can get the surveyors already know. We've already done site training, site surveyor training. Everybody knows if you're participating in one of our QI projects and you completed it, you already get the credit. And that's for each individual year you're participating. A recent link for breaking barriers says for 2024 says we don't have to fill it. Oh my God, it's like coming in fast and furious again. I'm so sorry. Says you don't have to submit. You don't have to submit it now, but you do have to submit it in the new year, basically. And that we understand that cancer committees meet in January, and so if you might want to talk about this with your cancer committee in January, that's fine. And you can then just click the yes, I'm participating. If you wanted to switch from COC to NAPBC credit or vice versa, so let's say this year you got COC credit because you were doing prompt. Prompt is over and you're not going to get NAPBC quality improvement credit anymore. You can apply for 2024 and get credit for NAPBC next year, even though you got credit for COC this year. But you can't double dip. You can't get both in the same year. So you can't do both COC and NAPBC in 2024. You have to choose one or the other, but you can switch. We've been doing this. Experience delays in reporting due to staffing. Yes, please do still put your stuff in and let us know. You know, one of the reasons there were fewer sites that we reported on in this current data collection was that there was an ARIA breach and many people use ARIA and so they could not collect their data. It's okay. Get it in when you can get it in. That would be great. And just let us know. Send us an email. If you don't get it in at all, that's a problem. But if you can let us know that it's forthcoming, we're open. We want people to do this. In 2023, we didn't really have people missing 3 or more appointments. This will be the last question. A patient misses 1, we try to identify the reason and help. Can we still participate? Yes, not only can you participate, but we would love to hear from you so that we can understand your practices and share your best practices with programs that might be struggling. And so absolutely participate. You know, we don't want everybody to have difficulty. We love people who are across the spectrum. And so if you're doing something that's working, we'd love you to participate and let us know and you'll still get credit. And so with that, it is 1:59. Don't forget to fill out your post survey. Please do contact us whenever you want. We are always available, happy to answer questions. We're so grateful you're participating and hopefully making a big difference for your patients and for your institutions. So with that, have a happy Thanksgiving, everybody.